I welcome Dr. Sriram Narayan for this scientific session. Please come, sir. He is MD Anesthesia from Mysore Medical College and joined Sri Jayadeva Institute of Cardiology as a lecturer. And later he was assistant professor in Ravindranath Tagore Institute of Cardiac Sciences. And also he joined Mallareddy Narayana Hospitals as a medical director and joined Sri Vaishnava Devi Narayana Hospital. And right now he is in Narayana Hridayalaya Hospital, Bangalore, as a senior consultant cardiac anesthetist. I welcome him for the scientific section, and I ask him to deliver his lecture on this topic, sir.
I am Dr. Sriman from Narayana Hridayalaya. Brief about Narayana Hridayalaya is an institution founded by Dr. Devi Shetty. He is a great visionarist in cardiac surgery. We roughly do around 750 cases a month in Narayana Hridayalaya, Bangalore only. Altogether, we do around 1,000 cases a month if we put together the other places. Across India, we have around 15 institutes. Roughly, we do around 1,500 cases a month. So, of this, heart transplant is one of the most amazing surgeries been done for a long time, still developing. I'll give you a brief note what is about heart transplant. So everybody is been not knowing much about heart transplant, and at least we should know about criteria of selecting the patient for heart transplant, what are the criteria are required and all that. So heart transplant broke back in 1967, 3rd December, Dr. Christian Barnard performed the first cardiac surgery, cardiac heart transplant in South Africa. That was the most amazing news. Some almost say around 50 years back. We are still developing that same. And the first cardiac transplant taken place in India was in 1968. Dr. P.K. Sen from KM Hospital, Mumbai, performed the heart transplant, and the patient survived only for 24 hours. And later on 3rd August 1994, Dr. Venugopal performed the heart transplant in AIIMS, Delhi. They were very successful. The first patient which Dr. Christian Barnard performed lived for 18 days. So this is the picture. The donor, the recipient. Recipient was an ex-boxer with end-stage ischemic cardiomyopathy. So Cape Town was the first place where heart transplant took place. After some 3-4 years, in 1970s and not, the number of transplants started to decline. It is mainly because of hyperacute rejection and infections that followed the heart transplant. There is a lot of decline. Again in 1983, when US FDA approved cyclosporine as a drug, then we restarted the heart transplant program picked up. And from 90s onwards, the heart transplant program has again a wave of upcycle. Patient selection criteria. So who requires a heart transplant? So patient on refractory cardiogenic shock requiring IABP or mechanical circulatory support like LVAD and all. Then cardiogenic shock requiring continuous inotropic therapy where it is not amendable for it cannot be removed from the medical therapy. And patients whose peak oxygen consumption of less than 10 ml per kg per minute, they are ideal for this one. More than that, they are not that suitable for heart transplant. And NHY classification 3rd or 4th class, despite maximal therapy, and recurrent therapy, patients still not able to move around, take care of themselves, and patient with recurrent left ventricular arrhythmias, despite implantable defibrillators, antiarrhythmic drugs, catheter ablation, all that, but still persisting life-threatening arrhythmias, all are require a heart transplant. Even end-stage congenital heart disease with no evidence of pulmonary hypertension, refractory angina without potential medical or surgical therapy are the patients who require heart transplant. Who is the ideal heart transplant patient? High risk of cardiac death and low risk of coexisting morbidities. Contraindications for heart transplant: recent or active malignancy, active infections, chronic active hepatitis B and C infections, immunosuppressors like HIV and AIDS, systemic illness with multi-organ involvement, advanced sarcoidosis or SLE, severe hepatic or renal dysfunction, severe pulmonary dysfunction, morbid obesity, and age more than 70 years are not taken for heart transplant. Then how you matching the donor and recipient is very, very important. Most of the time previously we used to only do ABO matching. Now ABO matching with HLA compatibility also required. We do other screening like panel reactive antigens, and patients on the list of waiting list. So also is very important, because we have to select the patients who are all on the waiting list. We see if the patient has having no any antibodies developed, they are first on line of treatment, or if the patient's donor's antigen is not present, those antibodies are not present in the donor, are acceptable for heart transplant. And also geographical location. Okay, patient is in South, North India, we are having a heart, it is difficult to take because time is very important. So ischemic time of less than 6 hours from the extraction of the heart to retransplantation is ideal. More than 6 hours is not acceptable. Ideally around 4 hours is acceptable. Donor recipient size matching. So one is oversize of the heart. So inability to close the chest is important because it causes cardiac compression. Majority of the patients are male to female. Whenever you transplant, you will have some amount of bigger heart which will get compressed. So they will also cause hyperperfusion syndrome. Undersizing will cause low output because the heart is not able to pump immediate to the requirement. So always we size the patient to around plus or minus around 25 to 30% of the weight of the corresponding patients. Heart transplant. There are two types of heart transplant. One is orthotopic and heterotopic. So orthotopic is the native heart is removed, native deceased heart is removed and replaced with a healthy donor heart. Heterotopic heart is a heart which is transplanted with the existing heart in position. So this is only try to help the failing heart to recover. So heterotopic heart transplants are not much in vogue. We do only orthotropic heart transplants. In that there are two types of this one. One is bicaval and biatrial. So biatrial is the commonest, but if you do biatrial, you have less of atrial contribution to the heart and more chance of having heart blocks. Bicaval approach is good, but it takes time. So your heart and if your surgeon is quite fast, able to finish within 4 hours, then okay. Otherwise, it's better to have a atrial approach. So heart transplant, there is to limit the ischemic donor time less than 6 hours preferably. Within 4 hours if you do is good. More than 4 hours to 6 hours acceptable. More than 6 hours not acceptable. If the patient is like having other coexisting disease like mild pulmonary hypertension or any other disease, so if you do within 4 hours is better. Actually, the other video is not playing. It is the where the donor heart is collected and transported with the ambulance. That video is not. Sorry, this video is not playing. So this is the heart which has come back to the. This is bicaval heart where we get the SVC, IVC there. Oh. This is the transplanted heart. So post-transplant, what are the problems we expect? Post-transplant, most important are mainly right ventricular failure, pulmonary hypertension, left ventricular failure, rhythm disturbance, coagulation abnormalities. Rejection, again we have 3 types of rejection. One is hyperacute rejection, acute rejection, chronic rejection, and infection. This hyperacute rejection is immediately within 24 hours to 48 hours, the patient having problems. Acute rejection is in the first week. Chronic rejection, maybe after a month, you have chronic rejection. So, right ventricular failure. So, how to deal with this? You have to reduce the pulmonary vascular resistance by either ventilation or pharmacological way or inotropic supports like milrinone. Preservation of the coronary perfusion is very important. Sometimes you will have air in the right coronary causing problem. Avoid distension because you have a T in place, so you see for the any distension is present or not. So don't allow the heart to distend. Pulmonary hypertension, avoid hypoxia, acidosis, and hypothermia. You hyperoxygenate your patient and hyperventilate, bring down hypercarbia, inodilators, nitric oxide, ilioprost and sildenafil are pulmonary vascular dilators. Left ventricular failure. Mainly you see how your rhythm is okay. Assess the TE, do hemodynamic study, see cardiac output. You increase inotropes, add inodilators or vasopressors. If still not, then add IABP, ECMO, or temporary VAD is one of the ways of treating left ventricular failure. Coagulation, avoid or minimize blood transfusion is very, very important. Don't give hyper this one. Use antifibrinolytics, optimal rewarming, reversal of heparin, use modified ultrafiltration after CPB, use TEG to diagnose your coagulation problems, use cell savior intraoperatively, and you also can use prothrombin or factor A, factor 7A for coagulation abnormalities. immediate hyperactive rejection caused by mainly due to HLA antibodies developing in the patient. So you have to increase your high dose of steroids, immunosuppressants, assisted medical support, mechanical support, or retransplant. So survival rate is around 82% in first year. 3 years survival rate is 74%, 10 years survival rate is 50%. This is as per the USA register, not Indian this one. So organ donation is very, very important. We have to, because the supply is very, very low, you have to, what you call, the patient relatives have been, a patient who has been brain dead, his relatives have to be told or convinced about organ donation, because it is one of the ways they can see the patient's organs, his eyes, his kidney working in some other patient and feel happy about he's still alive around us. And myths, some people think that if heart is donated, that heart is still the spirit is around us and all that, so it's not required, but you can tell them, see, it is a very noble cause by donating organs to anybody. And future trends is advancement in transplant technology with xenotransplantation or artificial hearts, sorry for mistakes, or potential newer, this one like 3D printing. Nowadays they are having a, the artificial streaks like mutton streaks, fish streaks are all been printed in 3D. We hope in future that we can order our hearts which are gone wrong to replace for us. Thank you for a patient hearing.